Welcome back to another episode of the Braun Performance and Rehab Podcast. Joining me today is Airelle Giordano, Dave Quammen, Erica Coffey, Phil Plisky, and Rayce Houser. The six of us are going to be diving into ACL rehab in a roundtable style. We're going to be reviewing a variety of considerations, including NMES and ACL rehabilitation, isometric exercise in ACL rehab, soft tissue work, and the importance of regaining range of motion, our thoughts on various return to sport and return to progression criteria, the importance of addressing gait, and so much more. I really appreciate these five incredible individuals and their time coming on and sharing all of the amazing insights that they have that way. I highly recommend you check out the work of these five individuals. They are all doing such great things in the space and represent some of the best minds in the world of ACL rehab. Episodes like this are made possible by our sponsors ISOFIT and Oro Muscles. For more on ISOFIT and Oro, you can check the description below. Enjoy. Erica, Airelle, Phil, Dave, Rayce, welcome to the podcast. I'm super excited to work with the five of you today. For people who aren't familiar with you, would you mind filling them in a little bit about who you are and all the incredible things that you do in this world of rehab that way?
Airelle Giordano. I'm the director of our physical therapy clinic and residency training at the University of Delaware, and I'm the incoming president of the American Academy of Sports Physical Therapy. I've been involved in ACL research with Lynn Snyder-Mackler's group at the University of Delaware for years, and super excited to be here and super excited about ACL non-op and post-operative.
Erica Coffey. I am the director of the UPMC Rehab Institute Sports Residency in Pittsburgh. I was a resident at part of that residency more than 2 decades ago. And I've been practicing since. I was the physical therapist for the Pittsburgh Ballet Theater for almost 20 years. And now I'm primarily in clinical care and then residency director.
Yeah, I'm Phil Plisky. I'm a professor in the PT and PhD programs at the University of Evansville. Also the director of our residency programs there. We have 4 of them, so I get to work with those. We founded the sports residency program back in 2007, so I do a lot there. And then I also get to play and be a consultant, a performance systems consultant in professional sports, in a bunch of different professional sports, so that's kind of fun.
I'm Rayce Houser. I'm a sports PT out in Portland, Oregon, working at a company called Roke. I'm also a PT educator with Rehab Renaissance and True Sports.
I'm Dave Quammen. I'm an athletic trainer. I've been with the U.S. ski and snowboard team for about 10 years. I took a little hiatus, finishing my PhD last year at the University of Utah. And now I do primarily late-stage ACL rehab and also working towards kind of revamping some of the return to sport assessments we do at the ski team. And I still dabble in a little education at the University of Utah athletic training program and see some outpatient people at my wife's PT clinic, Motion Utah in Park City.
That's absolutely incredible. And obviously the five of you seem to have this commonality in the passion for sports rehab that you have, and ultimately a robust experience as it relates to ACL rehab. And I think that ACL rehab is one of the most common topics that we see addressed. Yet, unfortunately, I think a lot of people can really lack this common understanding or common ground as far as how we progress someone, what our criteria look like, and what we do for this entire ACL epidemic that way. Obviously, it's one of the most common and one of the most debilitating sports injuries. And I think I see a huge array of approaches to treating and managing the injury that way. So just real quick, for people who aren't familiar with the ACL, the anatomical, physiological considerations, and just how the injury occurs that way, would one or two of you just real quick go through how the injury occurs and what kind of things we have to consider with the ACL that way?
I think one thing to keep in mind is how fast an ACL tear occurs. So it's in the neighborhood of like 50 milliseconds. Usually occurs with some kind of plant and some type of loaded rotation mechanism, whether it's your foot or your ski, and that twisting mechanism causes the ACL to tear, but it happens very, very rapidly outside of kind of the brain's ability to like consciously control the movement. So we're relying on really fast kind of compensatory mechanisms to prevent that, like a spinal reflex or the cerebellum. But I think the thing to keep in mind is how fast it occurs, and it's not something that we can consciously control.
And I know I've also seen a lot of data to suggest the reason, or at the rate at which it occurs, the anterior translation happens first before we see the valgus mechanism. So I know there's been some data to suggest that it's primarily that anterior translation first, and then as a secondary consequence, we start to see that tibial rotation or that valgus collapse. I'm going to kind of put this out there as more of a food for thought in terms of mechanism, and with the rate at which it occurs, could there be some sort of pre-activation mechanism that is at fault, kind of happening in the subconscious as to why this occurs, as it relates to plyometrics and some of those movement phenomena that we see in those sort of movements? My mind kind of relates to that pre-activation as a potential mechanism for injury. Maybe that pre-activation pattern is a faulty pattern, and then that's why we're seeing the ACL injury.
The only other thing I would add, carry into the story later, is that it's usually non-contact. So, it does happen contact, but non-contact is usually how it's happening. And so that's one of the reasons it's even harder to understand why this continues. We have lots of factors that we think are improving things, but we still can't get the re-tear rate or the initial rate lower than what it's been for quite some time.
Yeah, I love that point. I mean, obviously, it's real quick and easy to understand when you watch a football player get blown up by like a 300-pound lineman. Like, you take 300-pound dude head straight through the knee. Yeah, something's going to give. But when it's non-contact, it's certainly a lot more difficult to wrap our head around that way. And obviously, after this injury occurs, physical therapy, AT services, the whole rehab gamut that way is really essential to get an athlete back to what they want to do that way. So after this injury occurs, but before the surgery, I've certainly seen an uptick in what I would call pre-op physical therapy or pre-op rehab type of stuff that way. And personally, I've been a huge fan of that, but I haven't really seen one standardized approach to this. I've seen some people who literally have one pre-op PT visit and then they're getting surgery the next week. I've had others that go 6 to 8 weeks preoperatively that way. And I really, try and meet the individual where they're at, but I see a lot of different things in this space that way. And I'm curious to hear all of your thoughts. When someone tears their ACL, but surgery hasn't happened yet, what does that pre-op period look like for you? What kind of goals are we trying to work towards or address or consider that way prior to the surgery that way?
I think it really depends on the patient and the surgical plan and when their surgery is planned for. So if I only have, if I see a patient on Monday and they're scheduled for surgery on Friday, then what we're going to do is very different versus if I see a patient on Monday and they're scheduled for surgery in 6 or 8 weeks. I mean, the primary goal of prehab is to get that knee quiet, right? To get rid of swelling, to get full motion, to get their quad firing. And those are the bare minimums that you need to do prior to surgery. And the rest of it depends on how much time I have, how many insurance visits the patient has, because I don't want to burn through all of their insurance visits pre-op. And those are the two main factors. I mean, there can be a million others, but
Sure. Yeah, I think those are great. We typically want to get all of that. I think the couple things that I think maybe people miss, just beyond the standard, right, is I like to get that baseline uninvolved leg strength. I want to know if, as soon as possible after that injury, we're going to get our isokinetic strength there, as soon as possible, just so we have that to kind of go by. And then the other thing is certainly around the concept of education, because now we're not going to be dealing with, anesthesia, all that. Let's get them educated on what's going to happen. And then we start that begin with end in mind process. So here's your discharge checklist. Here's your return to sport checklist. Here's your milestone checklist. And this is what we're going to go through. And we'll keep revisiting that every single week in those checklists to say, this is how you're doing. And because I think ACL reconstruction rehab can be unbelievably daunting from a time, commitment, emotional, mental, psychological commitment is really, really challenging.
The things that we kind of think about our return to snow framework starts at stage 0, which is prehab. And the main goals is get them to 120 of flexion and make sure that their quad is firing as much as possible. For just anyone that doesn't have access to an isokinetic machine or anything that's more fancy, a high voluntary quad activation is really correlated with corticospinal excitability. So if they can't fire their quad, they're already getting this neuro kind of decreased excitability from their brain, and they should not have surgery until that gets resolved, because if they go into surgery with that, it's going to be significantly worse afterwards. So I think thinking about it from that standpoint, they should have a really high capacity to fire that quad prior to surgery and, be as functional as possible.
Dan, this kind of goes back to something that you'd mentioned earlier about whether or not we're doing stuff on the table or whether or not we're having them do like a 5-rep max for a back squat. I think some of this comes back to a previous point in regards to what the timeline looks like. I was taking into consideration swelling and pain with those movements. If we have lots of swelling, I'm probably going to be doing a little bit less in terms of the aggressiveness of the intensity of the exercise. But if swelling is pretty reasonable, and as we're going through exercises, on the floor in the gym, and we're not seeing a worsening in swelling, or maybe swelling continues to improve, I'll probably continue to push that because I know it's going to be a long rehab. I want to try to keep as many physical qualities up as I can, try to keep strength as high as we can, keep as much muscle mass in that quad as we can. So I'm going to try to keep them as active as I can, kind of within the constraints of their swelling. And then, me, I'm a big constraints guy in terms of exercise setup, and I'm going to assume that they're likely going to compensate in some way to offload that quad. So then it becomes setting up situations where I can try to drive as much stress to that quad as I can.
I think everyone's probably hit all the points. The only last one I would have to add, we know we have evidence that having that quiet knee is important for post-op. So really getting extension and being able to fire their quad and decreasing that swelling, but also working on gait. And so that they understand, not avoiding it. If they're not having active giving way right now, we can attempt to walk normal, decrease their fear with that, and have them be able to start that directly after surgery. That will help get their extension, keep the extension.
I love that point on the gait tie-in, because obviously it's great to have the range of motion and the strength, but it's even better if you can use it in a manner that means something to the athlete that way. And obviously, as you are all talking, fusion management, pain control, quad activation, full range of motion, all those things are very important prior to surgery, but they're also very important after surgery, in particular, regaining the extension range of motion in a very rapid timeline. And this is something that I think a lot of patients struggle with. And I think it's even more difficult now. We were talking on the ACL surgical roundtable episode that we did recently about the popularity of the IT band tenodesis or other extra-articular procedures to add additional stability to the knee. However, this tends to make range of motion restoration a lot more difficult to the patient. So I'm curious to hear all of your thoughts as it comes to post-op day one through that early stage of rehab that way. What does your preferred approach look like for restoring range of motion? Do we have any kind of dosing parameters that we like or don't like? Is 3 sets of 10 enough? How do we manage, the effusion that comes with that? And is there anything in particular that you found can be a real game changer for, restoring that quad muscular strength very fast after the surgery that way?
I think it's really variable. It depends on what the patient looks like coming in. I unfortunately had two post-op ACL evals come in at the exact same time last week, which was an adventure, trying to evaluate both of them simultaneously, but they could not have been more polar opposites. One of them, they were only 2 days post-op, so they both had good extension because they're locked in extension. But one could fire her quad immediately, do a straight leg raise. The other one, as of yesterday, which is a week and a half post, could still barely figure out a quad set. And so it really just depends on what's showing up in front of you, because it can be complete opposite ends of the spectrum. But obviously the goal is full passive extension, good quad set, good straight leg raise without a lag. And then if they look great and they're not swollen, you can push that. And if you're still working on trying to get this patient to figure out a quad set a week later, it's an entirely different ballgame.
I think, are you really looking at strength in that first week or two, or are you looking at activation? Have we lost all that strength from, 2 days ago? I don't necessarily think that's the case, but how long are we out from initial injury and all those factors? But again, it's getting the activation back of the quad, working that into gait training. The person that can't get a quad set can't hold the range of motion either. So you're going to end up having more than one problem there. And then they're going to be effused because they can't get the effusion out. They don't have muscle pumping action there either, and probably walking with a stiff leg. So I don't know that there's really dosing that we could tell you that is for every person within that first week or two, right? Just like Erica said, it's based on what they look like when they come in, and you're going to do more quad sets and start knee extensions. And things through walking and NMES and all these things with the one that looks better. And then the other one, you're going to have to focus more on quad sets and maybe adding FES to that and helping that person in a completely different way than the one that's doing better.
I know from a general like heuristic standpoint, kind of the rough dosage I kind of have in my head, and then based on patient presentation will kind of skew if I go more or less. But from a time standpoint, just working on extension, whether we're heel pops or heel propping or bag hangs, I'm probably shooting for like an hour throughout the day, at least. And the amount of time that they'll be able to tolerate that in one sitting probably is going to be pretty short to start, but hopefully over time they can progress to, handling larger bouts of time in one sitting. And then in terms of frequency for quad sets, I know I tend to be a little bit more on the aggressive side or high volume side, just because it's such a low intensity movement that, we can drive a lot of volume with this. And so I'm trying to have them shoot for at least 1,000 reps a day for that quad set. And then kind of a rough guideline for that is 100 reps every hour.
Yeah, it's certainly everything everyone has said is spot on and right where it needs to be. One of the things I like to think about that maybe just to try to give it a little bit different perspective is I always keep in mind that with it 12 hours, 18 hours, 24 hours ago, this knee was fully hyperextending and without any problem, because most surgeons will not let them out of the surgery if they don't have the right tension in the graft, right? So if we start with that premise, I think a lot of times we get to this, oh, it's scar tissue, oh, it's this, it's too early. Yes, eventually that does become the case. But I think if we start with the mindset that the only reason that they cannot get their knee to full hyperextension is swelling and quad control, then that really kind of defines what's going on. And then I also think about it in terms of, if we're not taking a scar tissue perspective, what's going on with the musculature around the knee, the soft tissue musculature? I mean, you have a trauma to a knee. We know what happens when the body is traumatized. Muscles start to splint, muscles start to tension. So are we really paying attention to doing soft tissue techniques during that time to really calm down that knee while we get that quad going again and getting that quad quickly, maintaining that extension?
Bill, I think you bring up a good point there. I imagine we've seen plenty of people who have not received like the best care, and we see them like 6 months out of surgery, and now they have contractures either distally in the hamstring, proximally in the calf, and then you do some sort of stretching technique, get a little bit of gain of range of motion. But yeah, I think you bring up a good point there with some of those soft tissue structures.
Yeah, I agree. I think early on soft tissue helps desensitize everything and can help really calm down kind of their just apprehension towards their knee, and just that blood flow is super helpful. I think the other aspect that usually gets lost is how awesome and crucial isometrics are early on. So we start isometrics at day one, if possible, anywhere from 60 to 90 degrees of knee extension or knee flexion, and just have them push. And doesn't have to be some massive contraction, but that I found that's the best way to get the quad to turn on. So people can still activate their quad in that position and not be able to do it in a quad set. And we shoot for 5 sets of 45 seconds with a 2-minute rest between. And if they can't do 45 seconds, then they just hold it for as long as they possibly can. But those are really, really beneficial for getting that quad back early on. And then it's something they're going to have to do their entire rehab is isometric knee extension. So it's good to just get them used to what that feels like early on.
You all brought up so many amazing points here, and there's a few things that I really want to kind of dive into a little more real quick. Obviously, STIM was brought up, and I think that everyone, or hopefully everyone, is using some type of NMES or STIM type modality in relation to their ACL rehab that way. Does anyone have any preferred dosing for that as far as pulse width, frequency, and so on that way? Because again, I've seen the gamut. I've seen some people go super low, some people go super high. I've seen some people only do 5 to 10 minutes a day, and I've seen other people tell their patients to go 2 to 4 hours a day at home with that. Obviously, all of these things are variable, and obviously there's a lot of gray area and the typical, it depends with this that way. But I'm curious if there's been any one approach or any one protocol with STIM that anyone's seen really good benefits from that way.
I'll hit that one. I think we probably hit that subject to death at this university. I have the page up right now with all our parameters, but we've studied this a lot. It was part of Lynn Snyder-Mackler's work early on, looking at an exercise group with and without NMES and the group that did exercise with NMES was better. This was Tony DeLito. And so Pittsburgh, Delaware, this has been validated in multiple places. I feel like it's gone quiet for a bit and it's coming back hard again. We found so many other factors that we think are causing re-tears and the initial, the really re-tears. We think we get them strong, but we don't fix all the problems, right? So people are bringing out, these last ditch efforts to try to add to it. So we know that the quad is inhibited after this surgery. We cannot tell that via, verbal, tactile, visual cues of any sort. We've done burst and superimposition testing to look at the central activation ratio of the quad. It's challenging to do. But with that, we've been able to then apply neuromuscular electrical stim and see that the inhibition of the quad, the lack of it working, has improved with that modality. So we'll use NMES until they're 80% LSI. And then we move them into, not just a home exercise program, but kind of the regular strengthening route. But we'll use NMES as an adjunct therapy until then. I think one of the misnomers about using NMES is that people usually do it while you're kicking. So they'll do an MVIC with the NMES. The purpose of dosing it and really firing that quad with the electrical stimulation is doing it on a quiet quad. So we do an MVIC, we get the number, say 200, and then an accurate dose would be 50% or more of the MVIC to turn that stim up while the quad is in a relaxed state. Another reason for doing that is because of the fatigue factor. So if you're contracting and stimming at the same time, you don't know that you're getting an accurate dose. When I can see what the stim is bringing the dose up to, because I can turn the stim up until they're recording 50% of that MVIC, I know I'm reaching that dose. Otherwise, you don't really know that. So we do 75 pulses per second, 400 microseconds, 12 seconds on, 50 seconds off. The rest should probably even be a hair longer, but we all know this takes time. So it's about a 12 to 15 minute intervention.
If I can have a copy of this recording, because I feel like I just say this over and over and over again, everything that Airelle just said.
I also think it's challenging to try this. It's not comfortable, right? People don't want to do it, although it's interesting because it's one of the passive things they get, but it's not ice or heat, right? People get used to it. And actually it helps with pain control as well. Once you get the dose up there. So they're sore, they feel something from this. And then, we want to get rid of it over time. So it's another way that we're testing them every single day without one rep maxing them on other equipment. We know we're really assessing the quad and not other musculature like the glute and the hamstring and other things. So we get that MVIC every day. So we're also following that. Is that increasing? Is it not increasing? If it's not, yet they're hitting that dose, then we're missing something else. We're missing compensations or a lack of progression somewhere else.
The one thing that we do differently, and it's just simply because it makes our surgeons more comfortable, is we're still stimming most of our patients in full extension, which unfortunately then we can't get an MVIC. But we did have a small number of patients with patellar fractures. And so almost everybody gets stimmed in full extension, certainly early on. And then if we're still struggling with strength later, I will then put people on the Biodex. But prior to the 8 to 12 week mark, our surgeons get a little queasy about that. So almost everyone's getting stimmed in full extension in Pittsburgh.
And at Pittsburgh, Kelly Fitzgerald saw that, right? When you do NMES and extension and the person is up to their capacity, it's usually around 30%. So you want to push that envelope as much as possible so that you can get the dose a little higher, but realize that someone usually cuts it off and it's going to be around 30. We will start our ACLs in 45 degrees of knee flexion and not 60 with NMES to start if they're bone, patellar bone, or quad tendon. And then we'll gradually increase that angle just to take some tension off of that graft site in the beginning.
Airelle has a really good article. I forget what it's called. It's like, why are we afraid of NMES or something, that like summarizes all this. But I think that the couple points that people usually miss is the pads have to be huge. So you can't do this with like a, like 2-inch circle pad because they won't be able to tolerate the intensity that they need to get to that 50% MVIC. And I think no one does that. Like, I just feel like everyone has these tiny little pads at every clinic. And then it's passive too. I think everyone thinks there's still a co-contraction there. And the patient just is sitting there hanging out, doing whatever they want. But that article from Delaware that Airelle's on does a really good job of just going over all those things, if anyone just as a reference.
We'll definitely link to that in the description after this airs that way. I love those points. Phil, you brought up an interesting point as well in relation to soft tissue quality that way. And I remember it was a couple of years ago, I think, that you posted an article in relation to trigger point formation following ACL reconstruction that way. And there was an individual that I was having a very difficult time getting extension back with. And we ended up doing a lot of work through posterior chain, hamstring, calves, different things that way. And that really, really helped him regain his extension range of motion wicked fast that way. So I certainly became bought into that concept of trigger point and other soft tissue work that way following ACL early on that way. I'm curious, just overall, based on your experience and approach that way, this was an area that I was personally very careful on just due to an infection risk standpoint that way. Obviously, I didn't want to be lathering someone up with like a cocoa butter or something like that day out from surgery that way. So I'm curious to hear what your thoughts were, if anyone else has any other thoughts on the soft tissue component following ACL that way. How early are we comfortable doing that, and what are we comfortable doing it on that way? Any, different musculature that way, or any different things that we like, whether that's, cupping's popular, scraping's popular. I personally don't dry needle that early, but some people would, that kind of thing that way.
I think there's a couple things to think about here. I always like to look at when multiple things are pointing toward the same concept, meaning, we're getting, if we just look at the discussion we just had with eStim, right? What is that doing? Well, it's got several great mechanisms that are helping, right? It has pain control. Well, what is it also doing? It's also decreasing inappropriate tone in the quad in areas that it shouldn't be, and normalizing it in areas that, so it's kind of got a very similar effect to any soft tissue, mobilization. Our whole goal, regardless of what we're doing, is to normalize that quad and normalize full knee hyperextension range of motion. Like that's our whole goal, particularly initially, and maintaining that throughout. So to get to the specific question, though, when am I going to do soft tissue? I'm probably pretty aggressive in it very early. What I think about it, I just think of it, I've got this barrier or this zone that I'm not going close to, right? And that is any open wound, right? So I'm staying away from that. And, but guess where the trigger point usually is in the quad? It's in the center of the rectus. Where is it in the gastroc? Well, it's in the heads of the gastroc, there. Where is it in the hamstring? And it's almost always substantially away from the surgical site. So I don't really have any problem with it. I just keep that zone there. I'll do it within 24 hours. One family friend had ACL reconstruction, was having a really hard time with pain control. And we kind of stumbled on something with that because he was even having so much pain that you just couldn't even relax at all. And we said, hey, you got a massage gun, right? Yeah, we do. Go use it on the other leg. That let him get to sleep that night and all that. It's again, just think about what we're doing with the neurological system in everything that was been said so far. I mean, when we talk about gait, that's purely neurological system. When we talk about eStim. So yeah, I'm going after that immediately. I'm just trying to influence the neurological system. Whether I'm hitting a trigger point or whether a trigger point's real or not, I have no idea. But with that said, if I use a good test-retest model where I go, all right, I started with 0 degrees of extension. Now I match the other side's 5 degrees of hyperextension. Then, maybe I don't fully understand the mechanism, but at least I know, it could be just purely pain control that I did, and it allowed them to relax into it. I don't know, but it is an important part.
No, I think that's a great point, Phil, and I like the way you outlined that. Earlier, Erica brought up the concept of, extension hopefully won't be an issue because they're hopefully locked in extension. I've found that sometimes, I'm not sure if it's a patient thing or what happens, but sometimes they come in with a locked brace, but the knee is actually bent within the brace itself. which is always an interesting turn of events when that comes in. And I think the soft tissue component that you just brought up, Phil, has been something that I've certainly went to try and help restore that early on, because I think just from an overall tightness standpoint, the more time we spend like this instead of this, the harder it is to restore that early on that way. And then I got to bring up the isometrics that Dave brought up that way because I'm a little bit of a nut about the ISOs that way. I absolutely love the 45-second duration. I'm a little biased because that's pretty much what I'm doing the majority of the time as well. And I like the concept too about starting that early on. One of the things that I've done actually is I've swapped out the four-way straight leg raise of 3 sets of 10 up and to the sides. And instead of that, I've been doing 45-second ISOs, overcoming ISOs just into a pad, all 4 directions that way. And I've personally found success with that, but that's also just me and my little clinical bubble out here. So I'm curious if anyone else has been incorporating the isometrics into the early stage, or how long they go throughout the rehab that way with isometric loading, and what kind of things they look at with the ISOs and the ACL rehab that way. Because again, I've personally found a lot of benefit from, whether it's getting the athlete to actually feel something kick on, or the tendon loading concepts that we get from, the prolonged isometric that way, especially in relation to the fact that we're likely harvesting a tendon graft for the ACL reconstruction itself that way. I'm interested to hear more about how you might apply isometrics in the rehab world that way.
Yeah, I know David kind of alluded to it earlier where he he mentioned like they start ASAP in terms of trying to get those like leg extension ISOs, especially in some sort of flex position. I'm the same way. Once they start getting some flexion range of motion, can tolerate it, especially if they can sit on the edge of the table comfortably. We're going to start doing a lot of those overcoming ISOs. Similar to what Airelle was saying, usually we're going to get some sort of daily max. And then from there, if I just want to do, if we're not talking about using stim and dosing that there, maybe we're going repeat ISOs on the 10 deck, staying within a certain bandwidth there. I've also seen anecdotally too, especially when it comes to a BTP graft, that if we incorporate these ISOs much earlier on, it seems like they have less pain when it comes to actually testing.
I think that's a great point. I think we're underloading the tendon from the beginning, right? Some people are nervous to do that. We know we're to treat it like a tendinopathy. We're not loading it enough. We should expect pain. That's going to happen. And if we don't attack it early, sometimes they're walking an extension, they're not firing their quad. So that tendon is really underloaded for quite some time. I think adding the ISOs is much better than the four-way hip. I've changed that over my career. And most often they're compensating in those four-way hip exercises anyway with TFL and everything and hip flexor. So I think it's a much, much better option.
And I just want to bring up the point for, especially with the quad tendons and trying to get in some ISOs with their hip extended, as well as various ranges of knee flexion as soon as they can tolerate it, which we've brought up already before. We've got a whole article published on that about various angles, hip and knee flexion angles, and trying to pull in that rectus femoris more, especially with the quad tendons.
Yeah, and I think Airelle mentioned the underloading the tendon. I think we underload the tendon throughout the entire rehab. I think we do a lot of open chain ISOs to make people feel good. And then we're like, okay, time to go to closed chain. And then we only go back to open chain ISOs if we have a problem. And I was talking to one of Airelle's colleagues, probably now Ito, who's at Wisconsin now, but he's done a lot of really cool research with patellar tendon grafts and patellar tendinopathies. And he was saying you need to do open chain ISOs the entire rehab if you want to appropriately load the tendon. Closed chain work does not load the tendon. So I think that's an important piece to keep in mind. And then the other thing with ISOs is I think some people get apprehensive to do them because they can hurt right away. The first set may hurt, and the second set should be better, and the third set should be even better, and the fourth set should be pain-free, and the fifth set should be like, okay, I feel great now. So clinicians have to go through those first 2 sets where it's like, this hurts 4 or 5 out of 10. Second set, this is a 4. Third set, this is a 3 or 2, and fourth, fifth should feel really good. But we can't stop at that first set because it's going to get better really rapidly.
No, I think that's a great point. It's just the analgesic effect that comes with the isometric exercise that way. And obviously, I personally like it when, someone does the exercise and they feel better afterwards that way. I think that's really essential. I'm also interested to hear a bit about progression criteria for the five of you that way. When is it that we start to progress people, and what do people have to do? What do our athletes have to do in order to earn that right to progress? Whether that's, hey, we're going to get rid of your brace and crutches now and you can start walking, or hey, we've got to start jumping or return to run that way. I'm curious, has there been any resources or any certain criteria that you found work really well for your rehabs that way, or that just continue to hold up in the literature and research side of things? Because I've seen a wide array and wide, gamut of different options when it comes to progression criteria. And I think that at least I haven't seen one widely used, accepted, standardized approach to everything yet. So I'm interested to hear your thoughts on progression criteria and various stages of rehab.
I would love to start the discussion on the early stages here because I want to get some experts' opinions on this because I've got my opinion, but it is just that. As far as I'm a really big believer in getting normalized gait as soon as possible, like as soon as possible. But the interesting thing about that and again, I'm truly asking this question. I like to keep someone on crutches with as much weight bearing as absolutely possible with as normalized gait as possible. And so I probably keep people on crutches longer. I don't, brace, that's purely if the surgeon requires a brace, great, that's fine. I don't have any criteria for that. But I do have normalized gait with crutches, probably sometimes can go maybe even up to 2 weeks. I know that probably is a little heretical in the world right now, but it is. I would rather see a good, solid weight bearing with full knee extension, normalized gait, excellent quad contraction. We're going to start with some. This is going to be cortical at this point in time, where we're getting it before we get it reflexive. But I'm curious everybody else's thoughts on that.
I couldn't agree more, Phil. People want to be off crutches. This is, a faster surgery now, and the incisions aren't as long, and they don't stay in the hospital, and there's all these things that have made it faster, but the healing is not faster, and the return to activity is now longer. So why not take some time being on those? And I do want to preface, we haven't really said this throughout the whole talk, but we're not talking about people with meniscal repairs or chondral lesions, right? So we're just talking about the ACL, I assume. And in those people, I think what we found in our retrospective study, comparing what we did to actually what we published for our protocol was too fast with effusion 10 years later, because effusion staying around longer, and this is my opinion, I think we're too busy. People would take a week off of work to get this surgery. Now, you can sit at home and they might be in a dependent position and they're swollen, they don't walk, they don't do muscle pumping things. And so it's sticking around longer. That causes the quad not to work as well longer. Gait is more of an issue. So I think getting that under control as fast as possible. We also are dealing with students on campus. So their parents drop them off after surgery and then they don't know what to do. And if you say you don't have to walk with a crutch, then all of a sudden they just did 10,000 steps in their day without crutches. So I think a great progression down is important, and letting them know that from the start so that they're not depressed, that they're not getting rid of the crutches. And the crutches is really to make them better so we can move faster once they're off them.
Gonna say I agree with that. I think that's a really good way to frame it for your patients. It's I know you want to get off crutches, but one, you have to meet these criteria of full extension, good quad set, good straight leg raise that leg, and a normal gait pattern. But also that we need to keep your knee quiet and not swollen so that it doesn't slow us down going forward, and trying to really hammer that part home so that people don't feel like they're being held back.
I know some individuals might use some sort of straight leg raise, certain number of repetitions, whether it's 10, 20, 30, in terms of discharging crutches to show adequate quadriceps control. Does anyone use a torque to body weight ratio as well? I've seen some people, this is not necessarily research back from what I've seen, but just more anecdotally, they'll use a 1.0 Newton meters per kilogram in terms of discharging crutches. Has anyone seen anything there?
I've seen 2 for jumping and 3 for sport, but I've never seen anything beyond that. Yeah, I think it's an interesting concept, but I really haven't seen much otherwise in relation to that. I would say the 2.0 and the 3.0 are the most common ones I see for torque to body weight, but I think the biggest variable I've seen with that is I've seen a lot of clinicians measure the moment arm differently. So obviously, if you measure your moment arm differently, you're going to get very different torque numbers. So I think that ultimately it's great to objectively assess stuff as a, criterion for progression different times, but ultimately we need to have as standardized of a way to do that as possible. By the same token, I've also seen clinicians that don't measure the angle that they're testing at, and we're just relying on our own two eyes to get the angle right. And, I've found my own, visible goniometer is nowhere near as accurate as I thought it was. So I still break out the, boring little tool and measure it every single time. And, it's still got a margin of error, but I feel better about using a standardized approach every time we test the same height box, the same angle on the goniometer, ensuring that the same person is measuring it from the same landmarks every time and so on that way. So I think the more you can standardize your process of testing objectively as it relates to the return to whatever activity criterion, the better off your data is going to be that way. And I would say the same goes for return to jumping and return to sport as well. Like there's so many different criterion out there, and I'm really interested to hear everyone's thoughts on that. Like I personally still use the UDEL return to run protocol for all of my return to runs that way, and it just goes exceptionally well every time. But I have certain criteria that I look for before we initiate that, whether that be objective testing, some different jumping and hopping numbers and that sort of thing that way. But I think that sometimes we can get lost in the data. Like I've been using force plates a lot clinically, and I get about 7 pages per jump. So it's very easy to, get lost on one little number not being where you want it to be. But by the same token, I think as long as you apply the context and the large buckets from that into consideration, then the majority of the time you're going to be okay.
I'd like to ask what everyone's doing for return to run. We're around an LSI of 80% before we're allowing running, but with a quiet knee. There's not any hard literature on that, but in speaking with some people that have been looking at lots of data sets, that seems to be where the force is attenuated better with the quad strength at that time, right? Interestingly, we had Brian Heigerscheit here as a guest this week, and his talk was amazing, although I guess frustrating on my point. At the end of the talk, he's discussing how he has this 15, 20-year data set, and they're in these top level D1 athletes, and even if they're 100% side to side strength and everything they could measure, their running gait is not symmetrical. And it's not symmetrical by 10, 15, 20% in people that look fantastic. And it's in the majority of people. And, so they're landing on a stiff knee still. I think that comes back to what are we doing really early on? And they're doing strategies to try to mitigate this. And we're not quite getting there, right? So to the naked eye, we can't see these things. The faster they run, the better they look, but not necessarily at kind of normal speed. We're doing the 80%. We have an Ultra G, which is nice. We don't use it for everyone, but it's nice to be able to add that to try to mitigate swelling as much as possible in the beginning, because we kind of have that extra timeline now.
It's a really interesting thing to me is I think, again, maybe unfortunately or fortunately been in this so long to see the swings from we used to use isokinetics and measuring all the time to everything was functional to now we're back to the, and it's I think we go too much into fads and pay attention to too many parameters too much at one time. But I look at it as, I think, I don't know if it's 80% or not. That's kind of what I use, and it's a good guideline. It's actually what I like about it is it gives the patient something to shoot for, motivation, because running is a big deal to them. So let's get some motivation to get that quad back. But like you say, they still have those asymmetries with gait that we can't see with the naked eye and that type of thing. So what I like to do in all cases is actually let's take it down and see what I can see with the naked eye, right? And so can I look at, we've talked extensively about quad strength, quiet knee, all that type of stuff. That's at the low level. And then we're talking about jumping and running, which is at the high level. But what are the things I can actually look at in between, right? So how can I look at, are they able to squat well? Are they able to lunge well? Are they able to balance well? And all of those lower level pieces that are moving, first of all, at a speed that I can see, and B, are they pain free? Because if they're not pain free in those things, you almost guaranteed, I mean, the research is very clear. When there is pain, neuromuscular control is altered in unpredictable ways. Sometimes EMG activity increases when there's pain. Sometimes it decreases. It increases in one area, but not another. And so that's that big wild card there. So if we can look at very simple movements and be sure that all of those are pain-free, I think we kind of skip over that too frequently. Or we spend too much time on that and we actually don't look at quad strength and isolated open kinetic chain exercise, right? So I think we've just got to bring a little bit of balance back to what we're doing.
So I know Chris Powers and his group over at USC, I think it was a couple years ago, they had published a study that was looking at roughly when running kinematics start to normalize based on quad LSI. I think 88% was the number they came to with that. And I want to say these individuals torque to body weight was right around 2.5 or 2.5. And it seems like one of the common questions that we get is, do we put more stock in LSI or do we put more stock in the 2.0 Newton meters per kilogram? One being like, okay, they demonstrate that they have the capacity, even though maybe LSI might be 60%, they still have that 2.0. Or do we put more stock in the LSI and the 80%? And it seems like maybe the literature suggests a little bit more stock in the LSI versus that torque to body weight ratio.
But I think it bears the question of why not both?
Yeah.
Right. Like, I mean, I think that's again, maybe it's not to sound old, but maybe it is our current media state where it's just like, let's get these, big statements out there of, single leg vertical jump replaces triple hop testing. It's like, well, let's back that up just a little bit here. It gives us different information. And should you be doing single leg vertical jump testing? Absolutely. There's no doubt about it, but it doesn't replace horizontal hopping. It's just different. So so I almost kind of see that same argument in, if you're looking at only, body weight, ratios, or if you're only looking at LSI, probably only, anytime we say only, we're probably getting ourselves into a bad area.
I mean, Phil, in the past 5 years, torque to body weight's been around a while, but now we have rate of torque development. We have steadiness when they're kicking with an MVIC. We have, right? So it's like, okay, I have inhibition potentially. So we're looking at MVICs, rate of torque development, full isokinetic spectrum testing, potentially burst testing, and look at inhibition, four series hop test, counter movement jump, vertical jump. Like now your testing's 3 hours long and any one of those variables is not going to be perfect. They could look really good on 90% of them, and then you have a really bad one. So you don't send them back to sport, or what do you do, right? It's only gotten, to me, more complicated, not easier at all.
Yeah, and that's the thing. I think we need to, for a long time in my career, one of the things I really did, and I think it was a big mistake, is like return to sport testing and discharge testing were these events, right? Like they were at a certain time frame. We're going to do 4 months and we're going to do 6 months and there were these big events versus how about weekly return to sport testing? Right. And then we kind of take away some of the overwhelm with ourselves. Right. I mean, because again, we don't have 3 hours to do all this testing. And we also maybe are a little bit more systematic and logical in our rehab process that why not have the patient know what goal we're shooting for? And why don't we know exactly what goal we're shooting for that week? And did we achieve it or not? We talked about that, how valuable that is in the eSTIM process, right? That we can see we're progressing the way we should be. So yeah, I'm kind of excited about, it's just testing. It's not discharge testing. It's not, we're just doing readiness testing, and we're going to make sure that you're ready on this parameter this week.
Yeah. I mean, that's such a great point, Phil. I think we should change return to sport assessments to like intervention assessments, because we don't have assessments that tell us someone's ready to go back to their sport. They don't predict performance. They don't predict future injury risk. They tell us, they give us an opportunity to like do an intervention. Is their RFD off? Is their power off? Is their strength off? And doing those more often give us more opportunities to do the right intervention. I think they're done too infrequently, and we put all this weight into like a 6-month test or a 9-month test, and we're like, you passed, you're ready to go at your sport, or you failed. They should just be done frequently, and they give us ideas of what we should be doing in rehab.
I love that point, and I'm a full believer in the weekly testing, and that's something that I've transitioned to in my own practice this year. And I found a lot of these different things can actually go really quick as long as you leave them set up. And if people are kind of used to the flow, it's like, okay, come in, we're going to do X, Y, and Z on the force plates. Then we're going to do this on the force plates. Then we're going to go do these 2 things. I can usually knock out a lot of things in less than 10 minutes the majority of the time that way. I think that the biggest thing with collecting all of this data is you have to do something with it, because I've seen a number of people that collect all these numbers and all this great stuff, and then they never actually look back at what they did. And I think that you all mentioned earlier about just being systematic in the way we do things. I mean, with the, capacity of different things like Google Sheets and Excel, and, the availability of YouTube tutorials nowadays, I feel like it's so easy to create a simple kind of dashboard where you can literally look at every ACL that you rehab almost like their own individual case study, and kind of study your own interventions as a clinician. Like, hey, look, we got them to these numbers at this point. How did we get them there? Or, hey, they were at these numbers at this point, and, they weren't ready for this, or, they didn't have the outcome that we wanted. Was there something that I missed? Ultimately, as we've all mentioned, this world is only getting more and more complicated. And I think that if you're not taking the time to look back and assess what you're actually doing and what the outcome was, then it's only going to get more complicated, because you're just going to be kind of drowned out in the world of data, as opposed to actually synthesizing it in a way that could actually apply to your clinical practice that way.
So I'm curious, Dan, when it comes to this more like what I call like informal testing, and sort of like every treatment session with them, we're sort of doing this sort of informal testing. If you're having them hop on the force plate once a week to maybe get some sort of objective data to kind of help guide decision making, how do you go out balancing potentially if they come in different times of the day, like that sort of diurnal variation, or just even day-to-day variations there?
No testing, in my opinion, as we've talked, is 100% perfect, because there are differences, right? I might have someone come in and they just double scoop pre-workout and they're ready to go through the wall that day and they jump their best, right? But I try to be very consistent in how I go about cueing things and different things that way, because I think if you use different language, you're going to get different outcomes. I leave the plates in the same spot. If it's thigh pull, I always test at a 60-degree angle on an ISO fit. Everything is as consistent as I can. And I also try to purposely schedule athletes at the same times week to week. We usually schedule months in advance. And we try to lock that in to be as consistent as we can. And like we talked about earlier, it's all about the progressions over time. I know there's going to be off days. Everyone is going to have that, but I want general trends to improve over time, right? And if we're not improving over time, then it's a question of, am I doing the right things? Jump height, for example. Yeah, there's going to be a day where they don't jump as high. There's always going to be data outliers. So it's more a matter of what is the long-term trend to me. And I would say the other piece, you asked more about the assessment and intervention side. The best example I can give was an individual who came into the clinic last week, initially eval 7 months out from second ACL tear, BTB, IT band tenodesis, meniscus repair. Last PT said, okay, you're good to go. And surgeon said, no, you're not, because just because you hit 6 months doesn't mean we're magically good. And I noticed her counter movement jump and squat jump. I try to keep this stuff really, really simple. Counter movement jump height and squat jump height were identical. So I was like, that's weird. Normally people counter movement jump higher because they use stretch shortening cycle. So that just led me to kind of question a little bit, like, are we using stretch shortening cycle? And then I did her thigh pull, and I am a firm believer in what's called the DSI, the Dynamic Strength Index. And her thigh pull number was really, really good, but that gave her a DSI that's really, really bad. So I took it just a step further, and this was just me just kind of experimenting out of curiosity. And we did empty barbell box squat to an 18-inch box with VBT, and she was unable to get that above 1 meter per second, which is considered, your strength speed zone, more of the speed side. So for her, I kind of looked at it and I was like, okay, so we have good isometric strength. She tests pretty good open chain, but there's something missing from a power component. She can't move fast. She's not using stretch shortening cycle. So far for her, I've kind of went down more of the power route with her, and we've been seeing improvement. Now, maybe that's the wrong thing to do. Maybe I looked at it wrong and misinterpreted what I've been doing. But that's kind of where my head has been at least on that specific case and several others comparable to that thus far.
No, I was gonna say I always feel like how they look that far out is probably a lot predicated on what they were doing up to that point. And I don't know, was her quad, did it look decent in terms of like strength or any of those numbers?
We were in the 70s, which considering she had been doing straight leg raises for months, I was happy with 70s. Obviously, things could always be better. Try really hard to bite my tongue and not throw stones at glass houses.
Because I always like to think that whatever stuff they were doing, leading up to that point probably largely predicates how well they're able to recruit fast twitch fibers, their muscle size, all that. And a lot of that's going to be implicated in terms of how they're performing for you in front of you. I don't want to say like they get good or bad PT. There's a lot of factors, what they were doing outside of PT and stuff. But yeah, I think with what you did, like you see a observable deficit in terms of power output. You then employ a strategy to try to address power output, and all that sounds reasonable.
The other piece to that story is this was second ACL tear, and that could be a whole separate podcast and a whole separate discussion about, how different this process becomes when it's the second or occasionally the third time around for someone, because obviously, I think everyone can admit that quad inhibition following one ACL is really hard. But when it's a second ACL and now we've got both ends of the extensor mechanism, quad tendon and patellar tendon disrupted, I find it's a lot more difficult for them to get quad back. But again, that could be a secondary conversation that way. I feel like we've covered a lot in relation to pre-op management, early stage management, and overall this concept of testing and progressions as it relates to rehabbing the ACL that way. Is there anything else that we missed?
Yeah, I know we kind of talked about this last time we had spoke, but definitely a big believer in like understanding the kinetics of that terminal task, whatever they have to get back to, because that's likely going to dictate how aggressive or how intense our interventions to some capacity need to try to be in the clinic, if we have the equipment available to do so. And one of the big things I look at, I know the 505 is a pretty popular test for people to look at in terms of like penultimate step and loading strategy and change of direction strategy and all that. And Damien Harper has posted a lot of good stuff or published a lot of good stuff in terms of deceleration kinetics and kinematics. And when we start looking at like the antepenultimate and penultimate step, those forces can be up to like 6 times one's body mass. And that's going to happen in a very, very short period of time. Like we'll say like 0.25 to 0.3 seconds. Essentially based off of that, how aggressive do we need to get to actually employ that similar sort of stress in the clinic? And so similar to you, Dan, like if I have free time, I go play around with stuff. And so I was like, okay, how high do I need to drop off a box to get close to 6 times my body weight going through one limb? And granted, this is gonna be a little bit different force vector. This is gonna be more vertical versus having that posterior force there. For double leg, I had to get close to a 60-inch box drop. And for single leg, it was 30 inches. I'm just thinking if we're trying to work on deceleration mechanics or at least an individual being able to tolerate those forces, we're probably underdosing our intensive or the intensity of the exercise that we're doing in clinic. So understanding what that terminal task is, how intense it is, and then being able to at least get close or approximate some of those stressors in clinic.
Rayce, quick question for you. All good points. Does landing surface matter?
I definitely think so in terms of, and we can even talk about the skill of the movement itself. Like I had a hard time on the Hawkins plates being able to like stabilize myself with all the cues it has me do and then eventually stand back up. So I think I did numerous trials to finally get an actual rep that counted. I also think surface matters in terms of compliance, because if we're if we're having a little bit more, or if a service that has a little bit more deformation and compliance, we're probably going to experience a little bit less forces. And one, we might also have a harder time just from like an overall stabilization standpoint. So definitely, I think that matters.
I think one other piece that I always think about is the ACL injury. We think of it as more of like a peripheral injury, but it's really a central injury. The things that we're fighting throughout the early stages, mid, and when they're returning to sport are all like neurologic issues. And it's all having a lot to do with communication between the brain and the knee and making those things run really, really fast, getting it back to kind of like light speed corrections. And the way I think about it is we're really good. If you think about the person and their ACLs like a race car, we're really good at building the race car back up. We can put new tires on it. We fix any like bumps, any damage to the outside of it. We put the person back in the car and we say like, how fast can you go 0 to 60? And we're like, this is the same as you were going 0 to 60 before injury. How fast can you do a quarter mile in a straight line? And it's the same. And then we're like, okay, you're going to go do a Formula One race. And they're like, what? Like, I haven't turned. I don't like, how am I going to do that? There's other cars on the track. And we forget about that piece of like the driver has to be ready to drive their car. We can't just like get their body ready. So just kind of thinking about it as it's a neurological insult, and we need to treat that and think about that throughout the whole kind of return to sport process.
I'm just curious, for those who do have the Biodex, are you guys using like any sort of eccentric quad strength measure as well to help guide return to sport or clearance?
We're not right now. We've fooled around with it. Again, it's like another measure, right? It just adds to the length. We're training that way with isokinetics, but we're not officially measuring it. We just met with one of the reps as well, and they were big proponents of that. But I can't say we've implemented it yet.
Yeah, we're the same. I mean, we're doing Biodex testing as a criteria for running or as a criteria for jumping, but not beyond that.
Awesome. For people who want to find out more about the five of you that way, where can they find you at? Is everyone in the Instagram era these days, or
I'm so bad with my LinkedIn. I don't even know what it is. I have to look it up.
David's
How about
looking it
email?
up too.
Email's a good one.
Email's good.
Email's great.
Whatever you want to
Google me.
share, whatever you want to share for people to connect with you.
Email is great. bomeb@upmc.edu.
And
Yeah,
then,
I'm the old guy. I guess I do have all the social media accounts there. Phil Plisky, pretty uncommon name, so pretty easy to go there. Best way to contact me for actual questions and things like that is probably through philplisky.com. That's probably the easiest.
saying I'm on Instagram, Rayce_Roke, or I'll be at Rehab Renaissance. Probably easiest way is just to send me a DM.
Yeah, Instagram is easy. I just had to double check mine, but it's Dave Quammen _PhD.
Link to all that in the description below. That way, if people want to reach out and get connected with you all and all the amazing work that you're doing, they can just click there. I really appreciate everyone's time and all the amazing insights that you offered in relation to the world of ACL rehab, whether it be stages, incorporation of STEM, and so on that way. Thank you so much.
Thanks, Dan.